Welcome to the Smart OB Med curriculum. Social media for advancing residency training in obstetric medicine. We here present to you a national collaboration between the Universities of Ottawa and Alberta. This research project has been generously funded by the Department of Medicine at the Montfort Hospital, empowering future physicians in the care of medically complex pregnancies. We hope you will enjoy it. Thanks so much for joining today. I'm Karina. I'm one of the GIM fellows at the University of Ottawa, and today we have two obstetric medicine experts with us. First is Dr. Karovitch. He's been working at the Ottawa Hospital for over 30 years and has special interest in general medicine, obstetric medicine, thrombosis, as well as in the care of patients of those with Turner syndrome. At the insistence of his long-term mentor, Dr. Aaron Keeley, he joined the Special Pregnancy Unit in 1996 and has been taking care of high-risk pregnant patients ever since. And we have Dr. David Aziz. He completed his OB and general internal medicine training at the University of Ottawa and newly joined the Ottawa Hospital as part of the obstetric medicine group. And he completed his training in Vancouver and in Ottawa for obstetric medicine. Thank you so much for joining today. I'll be presenting a case and asking you guys a couple questions. So we're going to jump right into a case. We have a 31-year-old G1. She's 30 weeks pregnant who moved to Canada from Cambodia 5 years ago, and she's presenting to the emergency department with dyspnea. Now, dyspnea is one of those symptoms that can make us a bit nervous in pregnancy, as it can be physiologic in the context of hormonal changes or enlarging gravid state, or it can be something more ominous like a PE. So what is your general approach when you see a pregnant patient who's coming in with dyspnea?
So I think differentiating physiologic pregnancy of dyspnea versus non-pregnancy associated causes versus pregnancy associated causes is kind of my approach. Physiologic pregnancy of dyspnea tends to occur kind of early on in first or second trimester, tends to be can be progressive, but generally not limiting. And important to know that it's gradual, so it doesn't come on sudden onset, and generally speaking, you have no associated symptoms, so you're not seeing any abnormalities on your vital signs or any other testing that you're doing. So, and your exam should be relatively normal for pregnancy normal. So that's kind of how I box physiologic pregnancy of dyspnea, although not everybody fits into that standard definition. And then the pregnancy associated things will kind of depend on trimester and depend on how far along in the pregnancy, but common things that we'll think about will be, pulmonary embolism, peripartum cardiomyopathy. In severe dramatic cases, you can even think of amniotic fluid embolism or rare things like that. And then you obviously have your common conditions like asthma or infection, pneumonia, and of course severe preeclampsia can also present with pulmonary edema and dyspnea. So it's a large differential. And I think narrowing down your differential depends on how far along in the pregnancy, what associated symptoms you're seeing, and of course what your exam findings are. And like any other, like outside of pregnancy, you have to have a reasonable degree of suspicion and then go down that path of testing for what the most likely diagnosis is.
Yeah, I mean, I agree. This is, people often ask me, how do you deal with dyspnea in pregnancy? It stresses me out. I don't know how to distinguish between normal and stuff that's really important and dangerous. And anybody who tells you, don't worry about it, they're lying. It's really hard. You have to have seen lots of patients to get a feel for what normal is. And that comes with experience. And then those red flags, don't ignore the fact that they're having pleuritic chest pain. Don't ignore the fact that, and your physical exam, I mean, even I take out my stethoscope and you're going to do a good cardiac exam, and those things are important. And there should be some perhaps red flags, again, chest pain, orthopnea, severe palpitations, obviously signs or symptoms of DVT. You just really need to take some time and do a proper history and physical and think about some of those red flags.
We'll walk through a bit more of her case. So she's known for mild asthma. She wasn't on any puffers prior to pregnancy, although up until when she presented to her first time in the emergency department, they did give her some. At that time, her exam showed mild tachycardia, heart rate of about 110. Her JVP was not elevated. There was possibly a soft murmur, but it was difficult to characterize. Her lungs were clear and she had no peripheral edema. She was discharged home at that time with a trial of Ventolin and budesonide, but this failed and she came a second time to the emergency department. Then she had a chest x-ray and an ECG, which were normal, but a D-dimer was elevated greater than 1,000. How do you go about deciding when to rule out a PE?
I'll take that one. So we get a lot of referrals for rule out PE in pregnancy because pregnant women have dyspnea. And so I think what's very important to remember is don't go down that path. Don't do the D-dimer unless you're down the path if you're thinking that PE is under differential diagnosis. If you really think this is physiologic and you really think that, you can stop. If you really think it's asthma, you can stop. If you really think it's her obstructive sleep apnea that's not being treated, you can stop. Go down the path we're going to talk about if PE is in your differential diagnosis. If it's not, don't go down there. So if they're in heart failure, it's okay if they have heart failure. But if you really do want to rule out PE, so up till recent years, we had no real way to do that except for imaging. So prediction models were never validated in pregnancy, but now there are a few. And the one that people will talk about is the years model. And that's why I use that with some caveats. And the years model is very simple, right? 3 points. Hemoptysis, which we rarely see with PEs and don't see a lot in pregnant women with PEs either. Signs of DVT. And PE is your most likely diagnosis. So unfortunately, that third criteria means you got to think. It's not an objective point. You have to do a history, you have to do a physical, and you have to decide, I really think PE is the most likely diagnosis. And that's what stresses people out, because do I think this is physiological or do I think PE is the most likely diagnosis? And the years said if you have a D-dimer less than 500, doesn't matter how many points you have, they don't have a PE. And if it's if you have no points, your D-dimer less than 1,000 is okay. Again, it's very hard for people to give 0 points when they're being asked to evaluate a patient for query PE in pregnancy, because then what you're saying is the person who sent the patient to you is down the wrong path completely. But anyways, that's the model. And in the trial, by doing that, they saved an overall 39% of CT scans, so maybe less than we thought. And they really had no recurrent events over a 3-month follow-up period. But the confidence intervals were up to about 1.2%. And there's experts around the world who don't like the fact that there's any wiggle room in those confidence intervals and think that unless you have a 100% foolproof model, you shouldn't apply it. I'm actually quite comfortable applying this model. I will never save 39% of CTs because I'm not as confident as saying there's another diagnosis and giving 0 points. I find that very challenging. And don't forget, in all studies, all prediction models looking at query PE in pregnancy, the prevalence rate is very low. So in the years, the Artemis trial that looked at the years model in pregnancy, the prevalence was only 4%, and that's not atypical. So I know when I'm asked to see a lady with rule-out PE, when I'm walking in the room, I've done no history or physical, I know there's already a 95% chance that this woman doesn't have a PE. Of course, if she has a PE, she has a PE. I don't go in there glibly, but these studies are challenging because the prevalence rate is so low. The other thing I'll say just quickly, in all these trials, the usefulness of Dopplers up front is very low. Women with no leg symptoms, less than 1%, you'll pick up a DVT. And even women with subtle symptoms, less than 10%. So I always think about, if I want to go down that path based on the years modeling, I just go to lung imaging. I don't waste my time doing leg Dopplers unless there's an obvious DVT.
So on the note of lung imaging, how do you guys go about counseling a woman and a pregnant woman who might be nervous about having that type of imaging done?
Can I take this one?
Yeah.
Because I do it a lot.
Yeah.
So we get referrals, and we often get referrals because I think every woman with rule-out PE and emerge should have a chest X-ray. There might be other reasons why she has dyspnea, and you need to be able to have that conversation if you're going to see pregnant women. So it takes some time. There's no reason not to get there. VQ scans and CT scans both are logarithmically less radiation in terms of rads to the fetus for congenital anomalies and even for carcinogenesis in childhood. There's no reason not to do this test. And I think women need to be told, and I'm very frank with my conversation, I say, look, there's a high likelihood you don't have a PE. So we're going to do this test and it might be normal. You shouldn't feel that was a wasteful test. We ruled out a potentially life-threatening illness. And treating when we don't know you have this is equally as dangerous. So you need to do this test and it's what's right for you, your health, and therefore your baby's health. So I package it that way. I talk about her health and how that's the most important thing for this baby's health. I've never not been able to do a test that I want.
So she was referred to thrombosis, as I'm sure you guys can expect. She had an urgent CTPA done. At that time, it showed mild pulmonary edema, a dilated pulmonary artery suggestive of pulmonary arterial hypertension. So an urgent echo was arranged 3 days later, and it showed rheumatic mitral stenosis. At that time, there was a mean gradient of 18, a peak gradient of 36, heart rate of 106, and a MVA of 1.9. Her EF was 63%, and she had mild pulmonary hypertension with RVSP of 45 and an enlarged left atrium. Cardio OB was consulted, but with a diagnosis of moderate rheumatic mitral stenosis, what are some of the considerations of management now, peripartum, as well in the postpartum period?
Sure. So
And there was no PE.
There
there
was
was
no
no
PE.
useful test nonetheless. Chest X-ray maybe give you that answer, but so for the now considerations of treatment, so from a pharmacologic standpoint, of course, the patient's coming in with pulmonary edema and dyspnea, and so trying to treat that would be kind of the first consideration. I think we treat pulmonary edema in pregnancy the same way we would outside of pregnancy, with, I think, the caveats of Lasix and being careful with amniotic fluid and getting that decision okayed by MFM as well when it comes to amniotic fluid status, but diuretics would be the mainstay of treatment, and they're safe in pregnancy. And then other treatment consideration would be beta blockade for one, augmenting diastolic filling time and reducing kind of that sinus tachycardia, which is also shortening your diastolic filling time as well.
I just want to say for our junior learners, this has to be a cardio-selective beta blocker, not labetalol.
Yeah, cardioselective. So those would be kind of your, I think, the two mainstays of therapy for the here and now. For considerations regarding delivery, there is, I think, lots of potential implications that you need to consider. Mode of delivery, safety of the mode of delivery, epidural location. So this should be managed in a center with cardio obstetrics, MFM, and anesthesia. And monitoring during the pregnancy, so whether or not an ART line is warranted, central line for venous access, telemetry, and of course, with moderate to severe mitral stenosis, there's an increased risk of atrial fibrillation, and with the stress of labor, that might be something that you can pick up on telemetry and would have very important management implications in this patient. So that would be something to keep an eye out for. And to touch very briefly on some postpartum and interpartum, there's the definitive treatment of the valve. And so I would defer that decision to cardiology, but of course, with moderate to severe disease, often some sort of stress testing is done to delineate the severity of disease, and then afterwards, a decision can be made on, the anatomy of the valve and what kind of valve definitive therapy might be done. And then there's, of course, the future considerations for future pregnancies. And one way I characterize risk and try to counsel women is using either CARPREG-2 or the modified WHO score, which give you some percentage-based risk of cardiac outcomes in pregnancy with women who have cardiac conditions. So I think that's just some of the key points, but there are others as well.
I'll just say that if you have someone with severe valvular heart disease in pregnancy, you need help. This should be done in a tertiary coronary center, lots of monitoring. They probably need to be delivered and watched in a monitored area, postpartum CCU, ICU. This is not going to happen in the birthing unit. And frequent monitoring in pregnancy with probably frequent serial echocardiograms to look at that valve area, the gradient, and the pulmonary pressures.
You brought up an interesting point about some of the complications, including atrial fibrillation. We'll talk about it in this case, but is there any guidance or evidence around anticoagulation in those who have AFib in pregnancy in the absence of some of the other risk factors that we worry about, like the CHAD score?
Very little data. I mean, a woman like this may have a very enlarged atrium and may be at high risk for atrial fibrillation. And as David said, the stress of labor and delivery. So most guidelines or most experts will say you probably should anticoagulate this woman for prevention of arterial thromboembolic disease. What the ideal therapy is in those situations is not known. Different guidelines talk about full anticoagulation with low molecular weight heparin. Some people talk about prophylactic doses or intermediate doses. We don't know. I think if women have atrial fibrillation in pregnancy, they should be anticoagulated for ATE protection and stroke prevention. How you do that and at what dose is somewhat debatable, but I use at least intermediate dose low molecular weight heparin. I might not use full dose low molecular weight heparin. We don't know what the equivalent of low molecular weight heparin is to oral therapy at preventing stroke outside of pregnancy, and certainly we don't know in pregnancy either.
And would you continue that just to a certain point postpartum?
I don't know. I think it depends. If she still has a dilated, and there's no reason why the dilated atrium would go away, and she's still in AFib, I would, because that's an ongoing risk. Ultimately, postpartum, you can start thinking about oral therapies. If they're not breastfeeding, a DOAC would be reasonable, and if they are breastfeeding, warfarin for sure.
So I'll give you a little bit more update about the case. So just to wrap up, she did have a bike stress echo that showed a valve area of less than 1.5 centimeters, and she had a significant rise in pulmonary pressures up to 62. Initially, the medications, as you talked about, Dr. Aziz, she was started on metoprolol 12.5 twice daily, as well as Lasix 40 daily, and her metoprolol was titrated up to target a heart rate of 60 to 80. She did have palpitations, but thankfully she had a Holter, which was negative for AFib, just some rare PACs and PVCs. And ultimately, a multidisciplinary meeting was held between obstetric medicine, MFM, anesthesia, and cardio OB, given she had NYHA class 3 symptoms. And the plan was for a planned elective C-section, which she had at 36 and 3 weeks. She had close monitoring in the cardiac care unit thereafter for 48 hours and was discharged on postpartum day 4 without any complications. She underwent a postpartum percutaneous transluminal mitral commiserotomy and did well with that. Dr. Karovitch, what would you say are some of the take-home key points for this case?
Oh, there's so many. I think dyspnea in pregnancy is challenging and stressful. Even after 30 years, I'm stressed when I'm asked to see a pregnant woman with dyspnea. I think distinguishing between benign entities and more serious ones is hard. You probably should never be really comfortable with that. I think you need to do a very fulsome assessment, history, physical. David mentioned some of those things. Look for those red flags. Is there something about this pregnancy is a bit different? Do they have associated symptoms like chest pain and sudden onset of symptoms and worsening of symptoms? And there's some things in my mind, I mean, it's specific to this case. I have to tell you, when I see a dyspneic pregnant woman, before I walk in the room, if she's from an endemic area of rheumatic heart disease in the world and she's ended her first, second trimester, early third trimester, I literally am walking into the room thinking this woman has mitral stenosis before I even take a history, and I'm not exaggerating. Rheumatic heart disease is common in the world, and that second, third trimester hemodynamic changes will unmask that mitral stenosis, even moderate disease. So that doesn't mean I don't think about other things like PEs and physiological changes, but I think there's some of those red flags. I mean, if she has a family history of VT, if she had previous SVT in the past, I might be more cognizant about thinking about PE. Watch for those red flags. And the other piece of advice is don't minimize symptoms based on demographics. So you walk into a room, you see a healthy looking 30-year-old woman. She has chest pain that's maybe consistent with ischemic heart disease. She could have ischemic heart disease. She can have SCAD. She can have spontaneous coronary artery dissection. Don't be biased when you walk into the room, and just be really thorough in your assessments. It doesn't mean you need to do everything for every patient, but you need to keep an open mind when you walk into the room.
That's great. Thank you both so much for discussing this today. Appreciate it.